Hello everyone, welcome back to my YouTube channel. My name is Dr. Hamid. In today's lecture, we are going to focus cirrhosis and portal hypertension. Again, very important topic for the preparation of USMLE Step 1 and Step 2, and I'm using first aid of USMLE Step 1. Now let's talk about cirrhosis. In the simple words, what is cirrhosis? It is diffuse bridging fibrosis and the formation of regenerative nodules that disturb the normal architecture of liver. Okay, normally the liver has very smooth architecture, but in the image A you can see there are nodules and fibrosis, formation of regenerative nodules and fibrosis within the liver parenchyma. This is not normal. Okay, the cells which are responsible for fibrosis and the formation of regenerative nodules are called ito cells, also called stellate cells. This is again very important point for exam point of view. The cells which are responsible for fibrosis within liver parenchyma are called stellate cells or ito cells. Okay, cirrhosis increases the risk of hepatocellular carcinoma. There are many risk factors for the hepatocellular carcinoma. One of these risk factors is cirrhosis. Okay, now let's talk about the etiologies or the causes or risk factors of cirrhosis. Number one and most important is alcohol. Prolonged alcoholism can increase the risk of fibrosis and formation of regenerative nodules in the liver parenchyma. If the person is non-alcoholic but has a steatohepatitis like metabolic syndrome can also increase the risk of cirrhosis. Chronic viral hepatitis like hepatitis B and C also increase the risk of cirrhosis. Other causes are autoimmune hepatitis, biliary diseases, genetic and metabolic disorders. These are all the etiologies of cirrhosis. Okay. Now, one of the most important complication of cirrhosis is portal hypertension. What is portal hypertension? When there is an increased pressure in the portal venous system, it is called portal hypertension. Normally, what happens is the two veins of the gut, superior mesenteric vein combined with another vein. I don't remember the name exactly. I'll mention that name in the description. When these two veins combine together, they form a portal vein. And when portal vein dumps that superior mesenteric vein and other vein, these two veins combine together to form a portal vein, and that portal vein is responsible for dumping of blood, the deoxygenated blood from the gut into the liver. And from the liver, that blood goes into the hepatic vein, and from there, it goes into the giant inferior vena cava, and from there, it enters into the right side of the heart. This is what normally happens. This is what normally how normally blood flows from the portal vein to the right side of the heart. But when there is liver cirrhosis, when there are fibrosis within the liver parenchyma, when there is regenerative nodules in the liver parenchyma, that portal vein cannot dump blood into the liver parenchyma and eventually cannot enter into the hepatic vein, then inferior vena cava and right side of the heart. So the backward pressure gets increased and the pressure within the portal venous system gets high because the blood keeps accumulating within the portal venous system. So the portal pressure gets high. Okay, this is how the portal hypertension occurs. But the thing here, the thing which is important and which you guys should remember, that only the cirrhosis is not the cause of portal hypertension. There are multiple causes of portal hypertension, but the most common cause in advanced in developed countries like America, the most common cause of portal hypertension is cirrhosis. Okay, other causes are vascular obstruction like portal vein thrombosis. When there is thrombi within the portal vein, it can also lead to portal hypertension. When there is thrombi within hepatic vein, which is called Budd-Chiari syndrome, can also lead to portal hypertension. And schistosomiasis, these are all the different causes of portal hypertension. Now look at this diagram, very important image. Here they are showing the complications related to portal hypertension. Okay. Complications related to cirrhosis, sorry, and then eventually portal hypertension. Now let's talk about the first. Let's talk about the symptoms. What could be the symptoms? First is anorexia, nausea, vomiting, dull abdominal pain, and fetal hepatitis, which is an odor, kind of a odor which we see in cirrhosis. Okay, these are the symptoms. Now let's talk about the effects of portal hypertension. When there is a portal hypertension, so the blood will flow backwards. that lead to esophageal and gastric varices, and that lead to hematemesis and melena. Okay, it can also lead to anorectal varices. Okay, and portal hypertension can lead to ascites. Eventually, it lead to spontaneous bacterial peritonitis. Okay, and then caput medusa. These are the effects of portal hypertension. Okay, because the blood is flowing backward and into the portal venous system, and then eventually into the esophageal and gastric veins that lead to gastric and esophageal varices, into the anorectal system lead to anorectal varices, and then ascites, and then SBP. Okay, renal complication can also occur, called hepatorenal syndrome. Some of the features you see on the skin, okay, like jaundice, yellowing of the sclera. You'll see spider angiomas. These are spider web like things on the chest. Palmar erythema, redness of the palm. Purpura and petechiae because of thrombocytopenia. Okay. Now let's talk about hematologic findings. Thrombocytopenia, anemia, coagulation disorders, and splenomegaly. Splenomegaly again because of the increased portal pressure, and blood will go backward into the splenic vein and lead to enlargement of the spleen, called splenomegaly. Coagulation disorders because liver is responsible for the formation of factor 2, 7, 9, 10. When these factors will not form, lead to coagulation disorders. Thrombocytopenia, why? Because of splenic sequestration, liver sequestration, and decreased production of thrombopoietin. These three things lead to thrombocytopenia. Okay, and metabolic features lead to hyperbilirubinemia, hyponatremia, hypoglycemia because impaired gluconeogenesis in the liver. Cardiovascular features include cardiomyopathy and peripheral edema. Reproductive features include testicular atrophy, gynecomastia, and amenorrhea. Why testicular atrophy and gynecomastia? Because when there is cirrhosis, there is increased adrenal production of estrogen precursors like androstenedione, and then these estrogen precursors aromatized into estrogen like estrone. Okay, there will be increased level of estrogen, and there will be increased level of sex hormone binding globulin. That sex hormone binding globulin will bind more free testosterone than estrogen. So the level of free testosterone will get low, and the level of estrogen gets high. Okay, whenever there is increased sex hormone binding globulin, that sex hormone binding globulin binds more free testosterone than free estrogen. So the level of free testosterone will gets low, and the level of free estrogen will gets high. When there is in low testosterone free when there is low free testosterone, it leads to testicular atrophy, and when there is high free estrogen, it leads to gynecomastia. Okay, basically in a nutshell, it is due to increased estrogen, and we know why there is increased estrogen, because of increased production of adrenal estrogen precursors, then aromatize to um, estrogen. Okay, we will talk about these all things in another lectures. We will cover all of these properly. Okay, um yeah. Now, here, before we start SBP, I want to talk about ascites. Okay, because again, ascites is very important. And why the ascites happens in cirrhosis? Because we know, in a simple words, because of the portal hypertension. Because when there is portal hypertension, and because of decreased synthetic function of the liver. In simple words, just remember that ascites is occurring because of the two reasons: because of increased portal hypertension, and because of decreased synthetic function of the liver. Because liver is responsible for the formation of albumin, and whenever there is liver cirrhosis, the formation of albumin gets low. The liver would not be able to produce enough albumin. And when there is low albumin, there will be low oncotic pressure in the vascular system. Okay. And due to portal hypertension, the hydrostatic pressure gets high. Whenever you know the normal physiology, whenever there is increased hydrostatic pressure and decrease oncotic pressure, there will be always movement of fluid from the vascular system into the interstitium. Okay, this is what happens in ascites. Okay, because of increase hydrostatic pressure because of the portal hypertension and decrease oncotic pressure because of low albumin, it leads to uh, what we can say, it leads to increase hydrostatic pressure and ascites. Okay, so let's talk about synthetic dysfunction in the liver. When the liver is not functioning, I have already talked about that there will be decreased production of albumin. Okay, there will be decreased production of coagulation factors 2, 7, 9, 10. Yeah, 2, 7, 9, 10. So that leads to, whenever there is decreased production of factors 2, 7, 9, 10, it leads to increased prothrombin time or PT and INR. Okay, and there will be increased blue ribbon. Okay, so you should remember that due to synthetic dysfunction in cirrhosis, it leads to decreased albumin, it leads to increased prothrombin time, and it leads to increased blue ribbon. Okay, now let's talk about ascites. How not only the cirrhosis is the cause of ascites, there are different causes of ascites, there are different etiologies of ascites. Okay, whenever there is ascites present, the etiology of the ascites, the cause of ascites, can be determined by serum ascites albumin gradient, SAAG or SAAG, in a simple word. I'm repeating again, whenever there is ascites, the etiology of ascites, the cause of ascites, can be determined by serum ascites albumin gradient. We check the serum, we check serum albumin minus ascites albumin. Okay, here let me show you. Let's open this first aid. Yeah, look at this. Etiologies of ascites by serum ascites albumin gradient. I'm not making things difficult. I'm just trying to make things simple. Whenever you see ascites, here I know we are talking about cirrhosis. Here we know that we are covering cirrhosis, and we know that cirrhosis is the cause of ascites for today's lecture. But I am trying to make things clear that not just cirrhosis is the cause of ascites. There are multiple causes of ascites, and how you can different how you can come to come to know that what is the cause of ascites. So we'll do serum ascites albumin gradient. Whenever there is a serum ascites albumin gradient, serum serum albumin, what is serum ascites albumin gradient? Serum albumin minus ascites albumin. Okay, so whenever there is a serum ascites albumin gradient more than 1.1, the cause of ascites is related to portal hypertension. Whenever the serum ascites albumin gradient less than 1.1, the cause of ascites is not related to portal hypertension. Okay, so now what are the causes related to portal hypertension? It could be one of three causes: pre-sinusoidal, sinusoidal, or post-sinusoidal. So pre-sinusoidal causes can be splenic or portal vein thrombosis or schistosomiasis. Sinusoidal causes is cirrhosis, and we are covering cirrhosis in today's lecture. Post-sinusoidal causes of ascites are right heart failure, constrictive pericarditis, and Budd-Chiari syndrome. Okay. Now let's talk about serum ascites albumin gradient. When the serum ascites albumin gradient is less than 1.1, it means it is not related to portal hypertension. The patient has ascites, but that ascites is not related to portal hypertension. So what could be the causes? Nephrotic syndrome, because there would be decreased albumin in nephrotic syndrome, because there is albumin urea or protein urea in the urine. So it will lead to decrease oncotic pressure, again increase hydrostatic pressure, and lead to a serum lead to ascites. Okay, TB, malignancy with peritoneal carcinomatosis, example ovarian cancer. These are the causes of ascites that are not related to portal hypertension. Here, if I'm seeing a patient, for example, a patient comes to me with ascites with a very big tummy, and I'm seeing that this patient has jaundice, spider angiomas, palmar erythema, and he's a male patient, so he's having testicular atrophy and some gynecomastia. Okay, and the patient is complaining of also complain of esophageal varices, for suppose. So I want to check the etiology of ascites. Okay, I'll do first. I will do the ascitic tap. Okay, I will pass syringe into the tummy and collect that ascitic fluid. Now I have this that ascitic fluid in my hand. Now what things I will check in that ascitic fluid in that tap? First, I will see grossly. I'll see the color of ascitic fluid. If that ascitic fluid is bloody, it could be due to trauma. During tap, it could rupture any vessel and can lead to bloody ascitic fluid. Okay, malignancy and TB, which is very rare cause of bloody ascitic fluid. When there is a milky ascitic fluid, think about chylus. Okay, when there is a turbid, think about infection. When there is straw colored ascitic fluid, think about benign causes. Okay, now let's talk about spontaneous bacterial peritonitis. Okay, whenever there is prolonged cirrhosis, not just the patient gets cirrhosis 3 days back. Whenever there is prolonged cirrhosis, okay, and there is prolonged ascites due to cirrhosis, it increases the risk of SBP, spontaneous bacterial peritonitis. Okay, and what is SBP? It is the infection of the ascitic fluid, and usually it is seen in advanced cirrhosis. Pathogenesis, what could be the reason? Pathogenesis is not very important for exam point of view, but you should know that whenever there is cirrhosis, there is an altered small intestinal motility, and when there is altered intestinal motility, it leads to bacterial overgrowth, and that bacteria translocate through the gut into the ascitic fluid and lead to infection of the ascitic fluid. Okay, in a simple words, what is the most common cause of SBP? The most common cause of SBP is E. coli. Okay, there are other organisms which are also responsible for cirrhosis, for SBP, but the most common is E. coli. The other organisms are Klebsiella, Staph aureus, Strep pneumo. Okay, these are the other organisms that can cause SBP. Okay, now how we diagnose SBP, come to know how we know definitively that this is SBP. We do the ascitic tap, we do paracentesis, and in the ascitic fluid, we see more than 250 polymorphoneutrophils, polymorphonuclear cells. If there is more than 250 polymorphonuclear cells in the ascitic fluid, more than 250 per millimeter cube neutrophils in the ascitic fluid, we say that this is SBP. Okay, the first line treatment for SBP is third generation cephalosporin, example cefotaxime, here they have mentioned. Okay, for the prophylaxis, we use fluoroquinolones, example ciprofloxacin, and for prophylaxis, we can also use TMP-SMX. But for exam point of view, I would say remember two things. For the treatment, we are using third generation cephalosporin, and we give antibiotic IV intravenously. And for prophylaxis, we use fluoroquinolones. Okay, how the patient usually present with SBP? They present with the fever, long-term cirrhosis, and ascites and features of cirrhosis. Along with that, patient will present with fever, chills, abdominal pain, nausea, vomiting, altered mental status. Okay, these are all the presentation findings of cirrhosis. Okay. Before we conclude our lecture, I want to share one important thing, that how we diagnose cirrhosis. The most we do liver profile, and we check AST and ALT. We'll talk about it later, but the most definitive test is liver biopsy. Okay, I hope I have made things clear. And if you guys have any question, you can ask in the comment section. I am here to repeat again and again to help you out. Okay, thank you so much.